Okay. Well, thanks very much. How many are in the room? I can't see the group. I have no idea who's there.
Sorry, it's about like 50 of us.
Okay. Oh, hello. Hello, everybody. Okay, so I'm going to talk to you about vertigo, my favorite topic. It certainly wasn't my favorite topic when I finished my residency. I did, a total of 5 years after medical school to become an emergency doctor, and when I was finished, I can guarantee you that I knew less about vertigo than anyone in this room. So it's only through practice and sort of self-learning that I became good at it. And so I'm going to share you some of the mistakes that I made and the things that I learned along the way. And the first thing I'll do is just go through this little slide presentation of how I feel you should be approaching vertigo. So there's my details. If you want to send me a question about a patient you saw or something, or any kind of question about vertigo, I'm happy to answer them. If you just search for my name, Peter Johns, on YouTube, you'll find my channel. And I'm also on X, Twitter, if you want to tweet about this, if you're into that sort of thing. I certainly have no financial disclosures, no big vertigo in my back pocket or anything. So first, what I'm not going to talk about is dizziness caused by general medical diagnoses. That's just emergency medicine. If somebody has complaints of dizziness plus something significant like chest pain and tachycardia, well, then you'd be worried about a PE. And if they were complaining of dizziness, shortness of breath, and cough, then you'd think more about pneumonia. And if they had dizziness and black stool, you'd be worried about having an upper GI bleed. So I'm not going to talk about the general medical causes. I'm going to talk about the vestibular disorders, which I'll define in a minute. Uh, Dizziness versus vertigo. There are definitions for dizziness versus vertigo. And if you look at the definition of dizziness, I've never really seen a patient complain of that sort of complaint. Like, what does dizziness mean? Well, it was a spatial disorientation without a distorted sense of motion. Okay, I've never heard that, but sometimes people will describe their vertigo as a true sense of self-motion, like spinning or tilting or a seesaw kind of motion, certainly. But the reality is that dizziness experts like to use the word dizziness and vertigo almost as the same because many people with dizziness have vertigo, but obviously not all do. So what do I mean when they are suffering from a vestibular disorder? We're talking about uh, the disorders that affect the inner ear where the organs of balance are. And that's this sort of thing here. If you can see this model, here's a cochlea where the hearing is. Then you got the utricle in the middle, which is for the up, down, forward, backward stuff. And then the semicircular canals for the angular movement. So that's vestibular disorders can come from that area, or they can come from the brain or cerebellum and the connections in between. So that's what vestibular disorders are. Now, generally, emergency doctors dislike vertigo. In fact, all doctors dislike, even neurologists and ENT, there's many of them who just cannot stand it. And why is that? And I think part of it is the phenomena that you might run into here.
Hey man, how's it going? Pretty good. Hey, do you remember that patient you saw last week?
So, we're worried that we're going to miss a serious cause of vertigo, and that's a legitimate concern. But are there ways of getting around it? Yes, and I'm going to go through that with you. So your primary goal as emergency doctors is make sure you don't miss a dangerous cause of vertigo because that's not good for the patient. It's not good for you. It's not good medical legally. It's just not good. But another thing that you want to do with patients with vestibular disorders is figure out what's wrong with them sometimes. It's not enough for the patient anyway. They're not really happy when you say, you haven't had a stroke, you can go home, but they have BPPV, which is something you can actually diagnose and treat, or vestibular migraine as well. So those are also goals that we should have as emergency physicians when we see patients with vertigo. So my approach to vertigo has sort of two stages of it. The first stage is looking for central features, which we'll define shortly, that are rarely seen in the benign causes, but you can see them in dangerous causes like mostly strokes. That's the first thing you want to do. The second thing that is helpful is if if you can definitively diagnose a non-dangerous cause of dizziness, then you can rule out a serious cause. And I had some people, when I've gone to my lecture, say, well, that's not something we normally do. And actually, we do that. If you saw someone with, say, pleuritic right chest pain and shortness of breath, and they looked fine otherwise, you did a chest x-ray and you saw small pneumothorax, spontaneous pneumothorax, they had nothing else to sound like a PE, you wouldn't work them up for a PE, right? So if you can definitively diagnose someone with a benign cause, you can rule out a serious cause, and that's what my approach is really doing. And so in order to become what I would say is vertigo competent, is if you can diagnose those three conditions. And the first one is posterior circulation stroke, because that's the one that we often misdiagnose, and it leads to bad consequences. And I sometimes abbreviate that to a dizzy stroke. And by that, I mean any stroke that has dizziness as a prominent part of their presentation. And then BPPV is the most common vestibular disorder we see, and it's very diagnosable and it's very treatable. And then vestibular neuritis is maybe not as common as BPPV, should be more common than vestibular neuritis, and it's often confused with posterior circulation stroke. And so when we miss a case of posterior circulation stroke, we're often making the diagnosis of vestibular neuritis. And just a little sideline. Some people call what is vestibular neuritis, they call it labyrinthitis. Labyrinthitis is where you have all the features of vestibular neuritis, plus you have hearing loss or tinnitus, because it's affecting not only the vestibular nerve, but affecting the whole labyrinth. And so you lose hearing loss or you have tinnitus. So that's what labyrinthitis is. And it's fairly rare, actually. I've only seen 2 or 3 cases in my whole career, but I've seen a lot of vestibular neuritis. So yeah, my approach to vertigo is in the Tintinelli's emergency textbook. If you just search on Google for CMAJ and my name, you'll see an article I published a few years ago. Or if you just search on videos on Google or YouTube, you'll find my YouTube channel, Big 3 of Vertigo. And I sent those videos to you beforehand. Hopefully you've had a chance to look at least some of them. So this is what my algorithm looks like in those articles. And I won't go through all these little stages box by box here, but if you'll notice that the Big 3 of Vertigo, it leads to those 3 diagnoses, the red one being the posterior circulation stroke, and then the not so dangerous ones, BPPV and vestibular neuritis. And you can make those diagnoses. You should be able to make those. And if you can, you are vertigo competent in my book. Now, about the history, a lot of people will say, I don't like seeing dizzy patients, not only because they're scared of missing a stroke, but because they're so vague and they don't really aren't helpful in the history. And now that, it's true that some of them are vague and difficult historians, but really the other thing is that we're not really very good at taking the history of a dizzy patient. So what are we going to ask them to help to get to the answer? And there's been, when I was many of your age, when I was your age, people will still say the most important question to ask is, what do you mean by dizzy? And if they say they're lightheaded, then it could be cardiac. And if they say they're spinning, well, then it's a true vestibular disorder. And if they say they can't walk, it's neurologic. And if they can't describe it, they're crazy. So it's been shown that that's not a reliable way of ruling in or ruling out any diagnosis. And that's not an uncommon phenomenon for us either. If you had a woman, and I'll give an example. I saw a woman who was about 35 years old, 20-week pregnant, comes in. I've had persistent heartburn for 24 hours now. I'm like, okay, you've had heartburn before? Yeah, usually goes away with my antacids, but it's not going away now. So, and she's in the least acute part of our emergency department. And I say, oh, anything else going on? And she goes, yeah, my left arm went numb too. Well, your left arm went numb. Well, that's kind of weird. So I did an ECG, normal. Did a troponin, slightly elevated. Sent her to the Heart Institute, our tertiary care thing, and she had a SCAD, a spontaneous coronary artery dissection. If I relied on the fact that she was describing it as heartburn, I would have missed that she was having a coronary artery dissection. And so that's why you don't want to, if someone just says they're lightheaded and not dizzy, that doesn't mean that they don't have a vestibular disorder. So what are better questions to ask? Asking what they're actually doing at the moment it came on, especially this is important for BPPV, which is so common. they'll often say they rolled over in bed and they got dizzy, or they lay down in bed or they got dizzy. And then they also, when they get out of bed, they'll get dizzy, which could be orthostatic hypotension, but you don't get a positive Dix-Hall spike in orthostatic hypotension. You want to ask for how long it lasted for, the duration of it. Is it short episodes? Is it long episodes in between? Are they still dizzy now? That's an important distinction as well. What makes it worse or can bring it on? Have you had previous episodes? Have you had just a few episodes in the past few days, or have you had a number of episodes of dizziness in your life, which make you think perhaps it could be something like vestibular migraine? And then you want to ask about the central features, which I'm going to get to shortly. If they have nausea and vomiting, it sort of can increase a chance of having a vestibular disorder, but it can be other things too, like orthostatic hypotension as well. If it affects their walking, if they said I've normally walked normally and now I can't, that's going to increase your chance of it being a vestibular disorder. And if they have a new hearing loss, that could be a peripheral cause, but it can also be a central cause. So you can't just, it used to be when I was in a residency, it was like if they had any kind of hearing symptoms, that meant it was peripheral and it can't be central. Not true. I've seen several cases where this was not true at all. And then if they have had many episodes in the past, you can start asking about the history of their migraine headaches, and that might help you as well. Obviously, if they have a lot of risk factors for stroke, that's going to get on your mind, but that doesn't mean people with risk factors for stroke can't have BPPV. So you need to make the diagnosis definitively. And in terms of nystagmus, a lot of people's hearts just sink when they see that the patient has nystagmus. They go, "Oh my God, they've got vertigo. Now I'm sunk." But really, that's like having an abnormal ECG. If you see somebody with chest pain with a normal ECG, now well, what could this be? But if you're seeing ST depressions or ST elevations, well, there's something going on. And if you see nystagmus, there's something going on. And the nystagmus is trying to tell you what's wrong. The patient's trying to tell you what's wrong. And the other thing is when you're looking carefully for nystagmus, don't just sort of look at them briefly and just say, okay, you don't have nystagmus. Look at them, get really close to their face, look really carefully. If they have little beats, you might miss it. If you don't see them when they're looking straight ahead, have them look about 30 degrees off to the side, not fully off, but just 30 degrees off to one side, and then have them look the other way. If they really have constant vertigo and you're still not seeing nystagmus, you can take a blank piece of paper and just say, look through that piece of paper as if it's not there. And that'll remove fixation because they won't be able to focus on this blank piece of paper. And that might bring out nystagmus that you wouldn't see if you didn't do that. And I had one of my colleagues do a CTA on this patient, kept her around for hours doing Dix-Hall pikes, all on this lady who actually had vestibular neuritis. And when I looked carefully, I could see nystagmus. And then the central features. So this is a key thing, and it's often sort of not emphasized when people talk about the HINTS exam or the HINTS studies. They don't emphasize that if they have central features like these, vestibular neuritis and BPPV are kind of off the table. They're likely to have a stroke if they're having a new significant headache. They'll be worried about a cerebral hemorrhage or even a posterior circulation ischemic stroke. If they have a new neck pain, then you're worried about vertebral artery dissection. I saw a woman who came in with a dizzy spell that lasts like half an hour. She vomited. She was just at the office and felt bad, and then it got better. She came in. Didn't sound like too much. She was all better. Any headache? No. Any neck pain? Yeah, my neck's been hurting for the past 4 days. I'm like, why is that? And she goes, I don't know. I went to the walk-in clinic. They said I must have strained it. You went to the walk-in clinic for your neck pain? And then I said, any tingling or numbness? Oh yeah, I had a little tingling in my left arm and it felt kind of wonky for a bit. It's all better now though. She had bilateral vertebral artery dissections. She looked totally fine. She was about 38, something like that. And that's all she had. And she had vertebral artery dissections, did well. And then you want to ask about focal weakness or paresthesias, because if you're looking for a stroke, look for stroke symptoms. You can see those kind of stroke symptoms in a posterior circulation stroke as well as an anterior circulation stroke. And then there's the particular posterior circulation stroke symptoms, sometimes called the deadly Ds, or I prefer to call it the dangerous Ds, because if you talk about it in front of the patient, it doesn't sound very good if you're asking if they have the deadly Ds. Anyway, if they have double vision, if they're having slurred speech, if they're having dysmetria, finger nose problems, or heel shin, difficulty swallowing, or hoarse voice, those are all things that shouldn't be in BPPV or vestibular neuritis. If you see them, you've got to think very strongly about a posterior circulation stroke. And then walking. If somebody can normally walk unaided and now they can't, you sit them up and they just fall over, or you stand them up and they're going to fall off to one side if you don't hold them. Those people should be worked up for a central cause, usually a stroke. You shouldn't be sending home somebody in a wheelchair. And then when you look for nystagmus, you do see vertical nystagmus. So it would look something like that, a vertical upward or vertical downward when they're at rest. And by at rest, I mean they're just lying there, sitting there. They've been there for a number of minutes, and yet you're still seeing the beating upwards or downwards. Those people are almost surely going to have a central cause. And then the real point of my big three of vertigo algorithm is to make sure that you do the right test on the right patient, because you don't do a Dix-Hallpike test and the Hintz exam on every patient. This is what I saw when Hintz first came up. That's what people were doing, and it was led to all kinds of difficulties. So here's an example of a woman that I saw actually a couple of decades ago now, and she was 72 and woke up with dizziness in the morning. And her history was that when she got out of bed to go to the bathroom, she got dizzy for a short time, and then she made it to the bathroom, made it back, lay down again, got dizzy again. And then she noticed when she turned over to the left, she would get dizzy when she turned to the left. And they were fairly short episodes, like 30 seconds. She didn't vomit, and she looked pretty good. And so this is sort of episodic dizziness. And the key thing here is that she was normal. She was feeling fine. And then she did something, which is got out of bed and got incredibly dizzy for a very short time, like about 30 seconds or so. And then it went down to either completely no dizziness, or sometimes they'll complain of a baseline dizziness. And then they do something else and it happens again, usually multiple times in the day. And then I'll tell you, she screened negative for all central features, and very important branch point in your decision of what you're going to do is that she had nystagmus at rest. And the answer is she did not. I looked carefully for it, she didn't. So what do you do next? And I think hopefully you'll know that what we should be doing is the Dix-Hallpike test. So yeah, so it's important that, you get them about 45 degrees turned one way and their chin up about 30 degrees, and you wait about, I did this very quickly. You wait about 30 seconds when the Dix-Hallpike position, and then you do the other test, and you might, you're looking for nystagmus, obviously, and the certain kind of nystagmus. What are we seeing now? I cannot see anything.
Yeah, and so now we're showing the nystagmus elicited on the left side.
Yeah, so this is the older lady. So it's vertical upward, beating upwards, and it's torsional, which means rotational towards the downwards left ear. And you're probably seeing some slow motion at some point. And that's to see the vertical or horizontal movement, you can look at the pupil or the whole iris. To look at the torsional, it's sometimes helpful to look at the red lines on the sclera, or she has a nice little mark that you can see. What are we looking at now there?
All right, so we're doing the slow motion now.
Okay.
We can move on to the next person. You did it on the left as well.
So this is a man who shows that when they look towards their downward ear, it's more it's more torsional, and then when they look towards their upward ear, it becomes more vertical. This is just something that you can see in BPPV. It explains why not everybody has the exactly same pattern of nystagmus, but it's not. It's just a typical Dix-Hallpike test, and the key point here is when you see vertical nystagmus, doesn't mean that they have a central cause. They don't need a CT head. You can't see the otoliths moving around on a CT scan.
All right, and then we're doing the slow-mo, and then this last part is looks like
the woman that I'm doing the Epley maneuver on.
Yes.
Yeah, so I mean, I'm not. This isn't the way I do it, because I was doing it in a way that I could get out of the way so you could see what her head was doing. But I usually sit on a stool and hold their head and support their head. And it's key to note that you leave them in each position for about a minute. And the first position is whatever side was positive, and then you turn after a minute, you turn them to the opposite side, keeping their head extended, and then you keep rotating the other way, the same way for another 90 degrees, so they're almost looking straight down for another minute, then you set them up.
But the
Oh yeah.
horizontal.
Yeah. So this guy is he's not having vertical upward nystagmus. He's not having torsional nystagmus. He's having horizontal nystagmus. So that if you see that, that suggests they have horizontal canal BPBV, which is in fact fairly common. And it's good for you to know about it so that if you see it, you'll have an idea of this isn't just something you can do an Epley maneuver on. You need a different diagnostic test and a different treatment.
And then you're showing the supine roll test.
Yeah. And so this one's when we turn his head to the right, you're also getting horizontal nystagmus, but it's beating towards the right. So it's beating towards the ground on both sides. So that's horizontal geotropic horizontal canal BPBV. And if you never learn how to diagnose this, I still think you're vertigo competent. But if you want to, get really sharp, you can learn how to diagnose this. And certainly, my colleagues who I've taught, they've picked up cases of horizontal canal BPV. One of our residents even had it. A man in his 20s had a horizontal canal BPPV. So it's actually fairly common. It's not uncommon at all. So now we're in the last stretch here of my little talk. There's a 75-year-old woman who's complaining of constant dizziness for 12 hours. She says it's when she does move her head, it gets worse. So there's a distinction where BPPV, where they aren't dizzy, and then they do something like roll over in bed, and they get very dizzy. Versus if you have other causes of dizziness, movement gets worse too. Almost every cause of dizziness gets worse when you move her head. But the key here is that once she stops moving, she still has a persistent, significant amount of dizziness. She also had some vomiting. She's had some difficulty walking, but she's able to walk unaided. And when you examine her, you do see nystagmus. So this is the acute vestibular syndrome, where you have persistent dizziness, difficulty walking, nausea, vomiting, worse with head movement, and you see nystagmus at rest. So most of those patients are going to have vestibular neuritis. Some will be having a posterior circulation stroke. And so their timeline is that they don't have any dizziness, and it ramps up fairly quickly to a very significant amount of dizziness, which the little bumps are where they do something that makes it worse for a short time, but they stay persistently dizzy for quite a while, hours, days usually, and then it goes off. So that's acute vestibular syndrome. And these are the people you really want to screen for the central features, because these are the patients where if they don't have any central features, they often do. First of all, posterior circulation strokes. People try and tell you that it's 25% of them don't have anything. I don't think that's true. I think it's lower than that. You just have to be careful and ask about all these different questions. So you've got to screen for all these things. So this lady, we asked her, she has no significant new headache or neck pain. She has no focal weakness or paresthesias, no dangerous Ds. And I list all 4 of them, 5 of them that I put. I described her gait. I would describe it as, she was unsteady, but she was able to walk unaided, and she only had horizontal nystagmus and not vertical nystagmus. And every patient with vestibular neuritis should have all these pertinent negatives written on the chart. I would question someone who would send somebody home with vestibular neuritis who didn't ask all these things. So what do we do with this patient? Now she's screened negative. Well, this is exactly the lady that you want to do the HINTS exam for. And when she looks to the right, it almost goes away. Is that what we're looking at now?
Yes.
Almost goes away, but then it starts you see little beats going to the left again.
So yeah, we see it very much not showing it on the right, and now we're doing test of skew.
Now she kind of has some saccades where she's looking back and forth. Any kind of horizontal movement doesn't count as test of skew. It has to be vertical or diagonal.
And you showed an example of what looked like vertical.
Yeah. So this guy's his whole eyelids are going up and down. So that's a positive test of skew.
And then you're doing the head impulse test now.
Yeah, so the head impulse test is abnormal when you turn the head in the opposite direction of the fast component of the nystagmus. So when I turn her head to the left, you don't see an abnormal head impulse test. But when I turn to the right, I usually go there when you see it, but I can't tell what you're seeing. So The HINTS exam, there's three components. There's, I'm listing them in the order which I do them. I always look for the nystagmus first because without nystagmus, you can't really do it. And then you do the test of skew, and then the head impulse test I do last because it's the one that's the patient doesn't tolerate quite as easily, but usually they will if you talk them through it. And it's the most difficult to perform and interpret, really, but it's not rocket science. You can do it. And then there's a result of each component, and they can either have a central result or they can have a peripheral result in all those three categories. If they have any of the hints central results, if they see you've seen nystagmus, it's changing direction. They're looking one way, it's beating that way. They look the other way, it's beating the other way. That's a stroke. I don't care what the other parts show. If you see abnormal skew, like we saw, I don't care what the other parts show, you're having a stroke. And if you do a head impulse test and you don't see a abnormal head impulse test, that's concerning for a stroke. Now that's counterintuitive because usually normal things are normal. If I do head impulse tests on all you in the audience, you probably all have a normal head impulse test and that's all good. But if you have a constant dizziness and nystagmus at rest, and I don't see a head impulse test, then I can't call you vestibular neuritis and I'm worried about a stroke. So that's that thing I talked about where you can only you can rule out a central cause by diagnosing for sure a peripheral cause. And on the peripheral side, you have to have all three components this way. You have to have nystagmus that doesn't change direction with gaze. You can't see any skew. And I'll have to see a head impulse test when you turn the head in the opposite direction of the nystagmus. I saw a guy from California sent me this case of where he missed the stroke, and he looked for nystagmus. He looked for test of skew, but he didn't feel confident with his head impulse test, so he didn't do it. He didn't bother doing it, and he missed a little stroke. The guy did well, but if you don't do the head impulse test, if you're only doing the other two components, you're missing the best part of uh, the HINTS exam, and I would encourage you to do all three. And in fact, there's actually one other part of the HINTS exam, which is the bedside test of hearing. Can you just say, can you hear that? Can you hear that? And if they can, that means they can hear and they don't have a new hearing loss, which the new hearing loss is to pick up an ICA stroke, an anterior inferior cerebellar artery stroke. That particular artery supplies the blood supply to part of the cerebellum and the pons, and also to this little guy, the labyrinth. So if you infarct that artery, you lose your hearing and you lose your sense of balance. So you'll look like a vestibular neuritis, except you'll have a new hearing loss as well. And that's why HINTS Plus is being used, and it can pick up an ICA stroke. So basically, that's I've shown you what the big three of Vertigo can do, and the way I use it, and the way I teach it, and that's sort of what I think you can do to become Vertigo competent. And the take-home points are ask the right questions on the history. Make sure you screen for central features. Do it even for the people that sound like they have BPPV, you know, and just get used to asking all the questions. Now, if somebody says any headache, and they go like, I had a bit of a headache yesterday. I took some Tylenol, went away. I think that's okay. Yeah. But if they say I've got dizziness and this is the worst headache, I don't get headaches like this. This is a really terrible headache. That's concerning. And then do the right test on the right patient. If they have short episodes, no nystagmus at rest, do the Dix-Hallpike test. They're having long episodes, hours, days, and see nystagmus, then do the HINTS exam. And if all their HINTS results are peripheral, plus they have no hearing loss, then you can send them home as vestibular neuritis. So that's all I've got for my lecture, and I'm hoping that you guys have some questions maybe about what I talked about, or maybe cases you've seen, or whatever you want to talk about.
Yeah, so any questions from the audience? We have a few, great. So Ola.
So I think the hints, it showed like sensitivities that were even better than MRIs and like ruling out stroke. So if you do your HINTS exam and it's negative, but sorry, that validity was really only shown in like specifically stroke trained neurologists. It was as studied in ED population. So now if you're doing your HINTS and it's negative, will you then like decide not to do an MRI in these patients?
I've in Canada, it's hard to get an MRI. And we're also have a different medical legal environment, I think, than you do in the United States. So the idea of doing an MRI on somebody with vestibular neuritis is just, it's not, you're not going to get it. You really, you'd have to show there's some kind of significant thing that would make you worry about. The other thing I would say is that I don't use hints negative and hints positive because it's unclear exactly what you mean. I use hints central and hints peripheral. If the overall hints is peripheral, and by that I mean the nystagmus doesn't change direction with gaze, they have no skew, and they have an abnormal head impulse test, then that's good. In fact, I saw on Twitter this guy say that in the UK that somebody said their hints exam was negative. And then so he asked, well, so just to be clear, what did the head impulse test show? And the answer was, we didn't do it, so it was negative. I mean, that's not the way to think about it. The head impulse test, you have to see an abnormal head impulse test to call it vestibular neuritis. They all have it.
I guess that leads on to actually my question. How do you think we should best teach kind of these skills doing the correct Dix-Hallpike and hints exam? Do you think this is something where, we should do it on our own, watch videos, kind of like your YouTube channel? Should we have workshops on this, kind of like they had in the studies, or just live demonstrations? What is your opinion on it?
Well, ideally, you would have somebody who has experience with doing these things watch you do it. That's ideally. And the Dix-Hallpike and Epley, although it's not that hard to do, it's not hard to do wrong either. I've had my colleagues, I've taught all my colleagues how to do it, and I've had residents who are working with somebody and they said, I was with somebody and they did the Epley, but they didn't do what you did. They did something else. So it's something that I think we have to be exposed to from medical school to residency and I think the people who start to learn at the medical student and residency level will tend to pick up on it and try it and they'll get better at it and it'll become part of their practice. I've got colleagues of mine who are my age or even older, and they're not going to learn this. They're set in their ways. So that's why I'm always happy to talk to residents because I think this is where you can decide, am I going to suck at Vertigo for my entire career, or am I going to spend a little time and help people with BPPV and not order a bunch of MRIs that don't need to be done? The head impulse test is probably the hardest thing for people to learn. The test of skew and the nystagmus, it's not crazy hard, but I think we're going to do a demonstration, hopefully, of one of you doing some of these things, and hopefully I'll be able to give some positive or negative feedback. But the head impulse test, I do think you have to have someone watch you do it who knows what they're doing. Is it possible you can just watch YouTube video and learn how to do it? That's how I learned. But I also actually did see both. I've had both Kata and David Newman Toker, the HINTS authors, see my head impulse test and say, "Yep, that's okay. You're doing it right."
Okay, Sam. Yeah.
Hey, Dr. Johns, big fan. So I had a couple of quick questions. One was I don't know that much about HINTS Plus. So when you talk about HINTS Plus and you're screening for new hearing loss, why couldn't that also be a labyrinthitis as opposed to?
Okay, so that's an excellent question. And the answer is we don't know if you take the average dizzy patient who comes to the emergency department, we don't know the incidence of labyrinthitis versus an ICA stroke. I've definitely seen one, and I've seen a few labyrinthitis. If you are a young person without risk factor for stroke, you screen negative for all the central features, and you say you've had a URI, and now it's led to your ear feeling kind of blocked, and it's painful, and you look in, you see a red drum, and then they develop nystagmus and dizziness and vomiting, and you see an abnormal head impulse test, and you test their hearing, and their hearing is down. I'm happy to call that labyrinthitis. Now, if you work at Johns Hopkins, you're getting an MRI. If you work in a small periphery place, you're not getting an MRI. And you wouldn't get one in my hospital, even though we have an MRI. If you see a woman who's old and she comes in and she's dizzy and she's got nystagmus and she's complaining of hearing loss and and she has maybe stroke risk factors and her eardrum looks totally normal and she hasn't had a cold, I'm going to call that no matter what she has, I'm going to call that an ICA stroke. And I've seen a patient come back with was sent home with vestibular neuritis, actually with labyrinthitis, and then came back and had a stroke. So it's something that we need to be aware of, and there may be some people we can be definitive, and then there's some people in the middle, and it's going to depend on your own medical legal environment, your ability to get an MRI, and that's sort of my answer for that.
Jamie?
You were saying that the Epley maneuver is gonna be helpful for, ATP that's originating in the canals, but for horizontal, like if someone has primarily horizontal nystagmus, that the Epley is not gonna be particularly helpful. And so what's the alternative? Is there an alternative like maneuver for treatment of that?
Yeah. Yeah, I one of the links that was sent to you, I hope, was on horizontal canal BPPV. It's a pretty good video. It's fairly succinct. It's 8 minutes long, and it tells you how you can diagnose and treat horizontal canal BPPV. When I first heard about horizontal canal BPV, I didn't really understand it, and I didn't test for it, and I never saw it. When you don't test for it, you never see it. And then finally something clicked, and I figured out how to test for it. And now it's about a third of the cases of people who sound like they have BPPV, in fact, or have BPPV, are horizontal canal BPPV. So you have to do the supine roll test, which is a different kind of test, and you have to know to treat. You can do the Gaffani maneuver. That's what I like, and I think it's important that you be aware of it. Once you say you've treated or you've diagnosed and treated 5 or 10 BPPV patients, probably somewhere in there you're going to see a horizontal canal, and it's going to make you wonder. I had some faculty development session with my colleagues who, again, some were older, many were younger, and none of them knew really about horizontal canal BPPV. And I demonstrated what it was and how you treat it. And 2 days later, I get a phone call, Peter, I've got a horizontal canal BPPV. Tell me how you do it again, how you do the Gaffani maneuver. So it's something that you can see. If you through your career you will see it. I saw that one of the first ones I saw was a woman who came in, had horizontal canal BPPV, got admitted to neurology, had an MRI, sent home without a diagnosis and without treatment. And then I saw she came back, I'm still dizzy. So I said, tested her. You've got horizontal canal BPPV. I cured her, sent her home.
Sam? Yeah, any questions from the attendings in the meantime? I actually have another one. What are your thoughts on the GRACE 3 guidelines? Like, is this a step in the right direction? There's still areas to learn?
Oh, okay. So if I share my screen, am I still sharing my screen?
No.
Okay, I got some
Actually, yeah, you are now. I have it up.
Okay, so here's some things I like about GRACE 3. It advocates for Vertigo training, which I think, I think in person is the best. And if you have enough attendings that become good at it, they can teach them at the medical school level, the residency level. So, it'd be great. But unfortunately, there's not that many Vertigo champions around right now. It also advocates for less reliance on diagnostic imaging, using the CT or the MRI. Certainly CT is almost useless for vertigo. The only time is if they had a real solid neurologic findings, or if they had a really significant headache, or if you're thinking of giving lytics, a CT might be useful, but otherwise they're not that useful. And the MRIs is good, but there's so many patients with BPPV and vestibular neuritis, you got to learn how to diagnose them so you don't waste all your time and money on MRIs. It also advocated for doing the Dix-Hallpike and the Epley and doing more hints. So all those things I like. What I don't like about that document is that it's 38 pages long, And if you read all 38 pages and understand it all, you're going to know Vertigo pretty well. But I found it a hard read, and I like Vertigo. I like reading about it. It was hard read. I read it all. Actually read it before it was printed. I gave some comments to the. I was asked to review it. It has 15. If you only read the 15 recommendations they give, you wouldn't know anything about Vertigo that you could help make a diagnosis. The 15, they just sort of recommend things, but they don't give the information. So my feeling is, if you're gonna, it's not a learning document. It's a statement document of what we should do, but it's not a paper to read. And now I know about Vertigo. I think it's too hard. What I don't like about Grace 3 in particular is that they don't emphasize screening for central features. They make it sound like, oh, of course you're going to do that, or they mention it. They kind of backloaded. If you see somebody who you think could have a TIA, then you should ask about symptoms. And they don't, when they talk about using the HINTS exam, they don't mention screening for central features directly in that recommendation. And they also, when they talk about patients who have constant dizziness without nystagmus, they don't give a good answer. Do you do a HINTS exam on somebody without nystagmus, or you don't do the HINTS exam on somebody with nystagmus? And I very strongly think if they don't have nystagmus in the first couple of days, everybody with vestibular neuritis who comes in and you're worried about a stroke, whatever, they're going to have nystagmus in the first couple of days. If they don't have nystagmus, you've sort of taken vestibular neuritis off the diagnosis. Now, again, you have to look very carefully for the nystagmus, but if you don't see nystagmus, it's off the differential. So what are you learning by doing the HINTS exam? Not very much. You're probably going to be worried about a stroke. Well, we can talk about that too in terms of the acute imbalance syndrome. And then the other thing I don't like about the Grace series, they call the positive Dix-Hallpike test vertigo. They call it upbeating. They hardly ever use the word vertical. I think they used it once, that it's vertical upwards, because there's so many CT scans. Probably there's been more CT scans done for positive head impulse, positive Dix-Hallpike test that showed vertical nystagmus than any other cause of vertigo. People see the vertical upward and they go, it's vertical. And then the Grace 3 didn't have any videos, which I didn't like either. So that's what I think about Grace 3.
I think for this last part, we have two people that are volunteer, kind of show a HINTS exam, mostly for
Okay.
kind of critique at this moment for all of us. Yeah, so you guys.
Good. Now how do I make it all big for me now here? I guess I just get out of here. I want to be able to see what you're doing.
Let me see if I can.
I'll stop sharing my screen and then, I see you. Yeah, okay, good.
Okay, great. Now,
All right. Okay, what are we doing here, guys?
All right, just a good angle here.
Yeah, that's good. What are we doing here? What are you gonna do?
So you want to start with a HINTS exam?
Sure, let's do that. Yep.
So HINTS exam, head impulse, nystagmus tested. You start with the nystagmus?
Yes. Yeah. But first of all, let's just make this clear. First of all, I make sure they have indications for a HINTS exam. So what are the indications for a HINTS exam?
So if they have like a vestibular syndrome where it's constant symptoms, can be worse with movement, but you need it to be constant. They need to have nystagmus at rest, and then no central features.
Yeah. Okay. All right. So now you're going to look for what kind of nystagmus he has. That's what you're going to do.
Right. So
Right.
I'm gonna first of all, I'm gonna have him just look about 30 degrees to either side and look for nystagmus. And as you said, fixation can sometimes suppress the nystagmus. So a good thing to do is, I don't have a white piece of paper with me, but I hold a white piece of paper and say, just look at the wall as if the paper wasn't there, and just have them sort of gaze. You would go one side and then the other side. If they have horizontal nystagmus where it's beating unilaterally, so whether they look left or right, it's beating to the same side.
It doesn't change direction. Yeah.
Then if you've got directionally changing nystagmus, so if they look right and they're beating right, if you look left, they're beating left, that's no good. So next we would do tested skew. This is probably the simplest one. You just essentially you have them just look straight forward at your nose or something like that, and then you just cover one eye like this, and then
You know what I do is I hold my hand far enough away from their face that I don't brush their nose because that tends to make them blink. So it doesn't have to be real far away, but just you don't want to touch their nose and make them blink.
Okay, so maybe somewhere like this, and then I'm just gonna instruct them to just like look at my nose or something like that.
Yep.
And uncover, and I'm looking.
No, well, hold on a sec. You go from covering one eye to directly covering the other eye. You don't ever uncover both eyes during this alternate cover test.
Well, I would, then in that case, I would come from here to here, and I would look.
Yeah.
Uncovered, and I'm looking for essentially like, ideally, I want them to just remain fixated on my nose. But if there's any sort of diagonal or vertical, I mean, you would call it skew, but colloquially like diagonal or vertical like movements
That's good.
back towards looking at my nose, that would be positive, and that would be a sense.
Yeah. And it's not a common thing you'll see, but you know, it's there. It does happen sometimes. Okay, and now the head impulse test, the most important one. All right, maybe turn your angle yourselves at another 45 degrees so I can. Now I want to see his head. I don't want to see your head. I know the other way around. Sorry, I want to see, yeah, the patient's head. Yep. Okay, good.
Okay, so first of all, I'm gonna explain what I'm doing, so nobody's surprised. I'm gonna go through it, tell them exactly what's gonna happen. I'm gonna move your neck. I'm gonna do it relatively quickly. Just try to relax. You know, I'm not gonna hurt you. Just say so. And then just I would grab them not by the mandible, but by the skull here, so I have a nice firm grip.
Yep.
I just move.
Okay,
them.
now, well, I always say when you do the first motions, all you're trying to do is make sure that their neck is relaxed, and you're trying to put them to sleep. You're trying to relax them. You're not trying to wake them up. So move your head like you're trying to rock a baby slowly to sleep. They're not real fast. Okay. Slow it down, even slower. Like just make sure his neck's relaxed. And he's looking, and if you notice, he's looking around. He's got to be looking at your nose the whole time. And those are fairly big movements. They don't have to be that far. They only have to be 20, 30 degrees to one side. I like that's good. And there's no, and you don't want to, no, you don't want to be up and down. No, you don't want to be up and down. Just keep it in the horizontal plane. That's right.
Small movements, just relax, making whale sounds, like speaking animals, and then I'm gonna come here, and I'm gonna make sure they're still focused on my nose, and then I do a quick movement like this.
That looked pretty good.
And the quick part of my movement isn't, I'm not going like through the whole 45 degrees quick, it's just maybe.
It doesn't have to be 45. It can be like 30.
Right, so like right here, I'll do it on this side so people can see, so like maybe at about right there, I would.
That's okay. Yeah, that's fair. But that looked pretty good. That looked pretty sharp. It's hard. No, it was a bit. The last one was kind of slow. The other ones were pretty quick. I don't know if he could tell. Could you tell the last one was a little slow? Oh, we're gonna switch. Okay, let's do a little dance here. Take off the glasses.
Here's going to sleep.
Okay, so no, don't turn it quite so much. So many degrees, and have them look at your nose, and yeah, okay. Now that was pretty slow. That was better. I sense you're not holding his head very, very tightly. If you squeeze his head as hard as you can, he will not complain of pain. His head will not blow up generally.
Is that one better?
So I'd like to see one or a couple more. That was good. That was good. It's not as good as the last one, but it was pretty good. Better than the first one. That's good. I like that. See, that's what you got to do. You cannot turn the head too fast during the head impulse test. You can, if you turn it too slow. Now that got a little wobbly there at the end. You didn't have a solid endpoint. That was kind of the Law and Order one.
Thanks, doctor.
Yeah, so the question is the corrective saccade, the one that's a peripheral, only going to be unilateral, only on one side?
The answer is yes, if they have vestibular neuritis. If you can get bilateral positive head impulse tests if you have bilateral vestibulopathy, which it doesn't usually present to the emergency department. It's kind of rare. And usually they complain of imbalance and dizziness that's been going on and gradually getting worse. And so, yeah, it should be only in one direction, and it should be, as I say, in the direction of the opposite direction of the fast component of the nystagmus. We have time for, are we finishing in 4 minutes or something?
Yeah, we probably gonna be wrapping up pretty soon. I
Good.
myself have one more question.
Yeah.
A lot of patients have physiologic nystagmus if you have them go to end gaze.
Yes.
And you can actually see different directional nystagmus.
Yes.
How do you get around that? How do you make sure that
Okay.
you don't overinterpret that?
Okay, so you're talking about end gaze nystagmus or endpoint nystagmus. Basically, if you direct your gaze, your own gaze, way really far, you can feel your eye muscles kind of like straining. And you can't. It's not like you can just move to the very end and it doesn't feel kind of odd. You feel them straining. And so if you do that, some people will have little beats that'll stop, or some people have little beats beating to the horizontally towards where you're looking and they won't stop. And that's end gaze nystagmus, and that's a normal physiological thing. And if you do it the other way, the same thing happens. Those people will not have nystagmus, spontaneous nystagmus. If you're looking straight ahead, if they're going like this, and then they look this way and it goes this way, and then you look the other way and it's going the other way, that's not right. And the other thing is if they are looking way out there, you just ask them to move their gaze in a bit to they're only 30 degrees off. And then if it goes away, that was end gaze nystagmus. So I've seen that a few times. It's not that uncommon, and it can fool you, but the difference is that it's only on the end of gaze. Now, the one way to know if you're asking the patient to look too far, if you want to know what too far is, close one of your eyes. Everybody in the audience can do this. Look at your finger and start moving it in the same direction as your closed eye. Once you don't see the finger, that's too far. You don't have to move it that far. You only have to move once you lose binocular vision, you're heading into end gaze area.
Good. All right. Any last final questions?
Super quick one.
Yeah, one more question. Yeah.
If you see a patient whose story is just so good for BPPT, but your diagnostic tests like your Dix Hallpike, you're not able to elicit nystagmus, that's it? You're 100% sure that they don't have BPPV, you have to seek alternate explanations, or would you still attempt an epi or a Bafani?
Okay, so when you do the Dix Hallpike test, you don't see nystagmus, but does the patient get dizzy?
Yes, let's say yes.
Pardon me?
Let's say yes.
Yeah.
Okay, so there's something called subjective BPPV. Some people think it's very common. I find it fairly rare, and many people think it's fairly rare. What that means is you do a Dix Hallpike test. Say you do one side, patient said, "No, I'm fine." You sit them up, do the other side, and they have the typical response in that they have a latency of 3 seconds where nothing happens. Then they go, "Oh, I'm getting dizzy. I'm getting dizzy," and then you don't see nystagmus. And then after 15, 20, 30 seconds, they say it's gone now. That could be subjective BPPV. If I saw that, I would go ahead and do an Epley maneuver for sure. But if you first of all, the Dix Hallpike test is not always, even if you have regular BPPV, it's not always positive the first time. If I do both sides and they really sound like it, what I do is I sit them up again. And then I'll say, okay, we're going to do the same test again. We're going to do this a little faster. And I'll have them sit down rather than going like 1, 2, like this. I'll have them go fairly fast. Not like bang, but faster. And then I'll do it again. And then if you don't, then this is key. And this is where we talked about horizontal canal BPB. If you see a negative Dix Hallpike test on both sides, that's when you do the horizontal or the supine roll test. But yeah, subjective BPV, I've probably seen 2 cases out of all the cases I've seen. The other thing to think about is that people with vestibular migraine, which we never talked about, unfortunately, that's too bad because it's a pretty big topic. Some of those people will have positional dizziness, but no nystagmus, and some will have nystagmus, but That's another consideration.
Yeah, I think that's all our time. Thank you very much, Dr. Johns, for coming and giving us this lecture.
Oh, you're welcome.